Good afternoon, and thank you for taking the time to join us for this webinar. My name is Shanti Singh Anthony, the Knowledge Coordinator for PANCAP based at the PANCAP Coordinating Unit in Georgetown, and I'm pleased to be your moderator for today's webinar. Let me extend a warm welcome to you on behalf of the Pan-Caribbean Partnership Against HIV and AIDS and PANCAP's Director, Mr. Derek Springer, and thank you in advance for joining us. PANCAP continues to serve as the knowledge hub for the region, and through this forum, we're pleased to share new evidence-based clinical and public health research, updates, and promising practices and best and successful interventions in the HIV response. Through this forum, we also facilitate a greater understanding of the barriers, challenges, and gaps in the regional response, and moreover, we propose recommendations for addressing these. Today, we have a really interesting topic, not talked about a lot, but in fact, really very significant to the HIV response. Histoplasmosis, in fact, has been classified by the World Health Organization as a neglected tropical disease. But more recently, in fact, this month, the question was raised whether it's a neglected tropical disease or whether it's a re-emerging tropical disease. And there has been evidence to show that there has been an increase in histoplasmosis among HIV patients. And so we do have an interesting presentation for us this afternoon. With that as a background, a few logistic and operational points to note. Firstly, your mics are muted. If you have questions as the presentation progresses, please note these down. We will address them during the question and answer segment at the end. Secondly, we will take the presentations and then this will be followed by your questions. Finally, the webinar will be recorded and shared on the PANCAP website for the benefit of the greater partnership. Today we'll be hearing, like I said, on histoplasmosis and specifically histoplasmosis among HIV patients from Professor Mathieu Nacher. A little bit on Professor Mathieu Nacher. He's a professor in epidemiology, health economics, and prevention. He's the director for the Center of Clinical Investigation, University of Guyane, French Guiana, director of their HIV program. He serves as a member of the scientific committee at the Center for the Study of Amazonian Biodiversity, a consortium of more than 100 researchers. He is an adjunct associate professor, Faculty of Public Health and Tropical Medicine, Tulane University, New Orleans, and coordinates and teaches in public health and statistics at the Faculty of Medicine for first and third year residents, MSc students, and serves as an advisor for MSc and PhD students. He's written many chapters in textbooks, including on immunity of parasitic diseases, tropical oncology, ecology and evolution for the control of infectious diseases in low-income countries, broadening the scope for public health management. He serves as a reviewer for more than 20 scientific journals, including for Lancet, AIDS, Journal of Infectious Diseases, and for many other tropical medicine journals. I now hand you over to Professor Mathieu
Nacher. Thank you, Shanti. Hello, everyone. I'm very happy to give this talk about a topic that is very dear to me. So, histoplasmosis in HIV-infected patients. So, let's see if this works. Yes. Okay, so histoplasmosis, in fact, has been discovered over a century ago in Panama, and it was discovered in a patient from the Caribbean, from Martinique. And it was thought to be initially a TB patient, and when looking closer, it wasn't TB, it was histoplasmosis. This confusion and this differential diagnosis is still very common today, and we'll talk more about that later. So Histoplasma capsulatum is a dimorphic fungus. It's a mold in the environment, and then when it's in the body, it transforms into a yeast. And here you see on the right of the nucleus of this cell, you see capsules, and that's why it's called Histoplasma capsulatum. Usually people get infected by inhaling spores, and these spores grow usually on bird or bat guano, like in bird coops or in caves. A lot of infections are due to visits like in caves or old houses where bats can be found, or in hollow trees. And these are the situations where you can get even epidemics. In non-immunosuppressed patients, it is very common in some areas in the Mississippi Valley. In some parts, over 90% of the population is positive. In the Amazon area, it's about 30%. So it's everywhere. But usually when you have no HIV, there are no symptoms, or the illness is very mild and looks like a common cold. In a minority, you may still have some very severe presentations, notably in cases where you go in a cave and you have a massive inhalation of spores. And histoplasma can survive after the acute infection in some old foci, and in HIV patients, as the immune system weakens, the infection may wake up. So HIV patients can get new infections, but they can also have the awakening of old infections. So histoplasmosis has been an AIDS-defining infection since 1987, and the first case associated with AIDS was described in 1981. And usually it occurs below 200 CD4 cells, and even more as you go below 100. So in HIV-infected patients with the impairment of the cellular immunity, you have increased incidence rates, and the illness is no longer mostly asymptomatic, but it's mostly disseminated because there's no more defense against the fungus, and it disseminates through the lymph nodes and bone marrow. And in about 20% of patients, you may have a very severe presentation which looks like a septic shock with very high early mortality. In endemic areas where it is known, mortality is about 40% historically, and it can be much higher if it is not known, if there are no diagnostic tools. In non-endemic areas, mortality is higher because often it is unrecognized and mistaken for TB. So in the septic shock-like cases, in the severe histo cases, mortality is even higher. And again, as in the first observation by Darling, it's often mistaken for tuberculosis. So I'm speaking from French Guiana, which is next to Suriname. And what does AIDS look like in French Guiana? Well, AIDS looks like histoplasmosis. Histoplasmosis is the #1 opportunistic infection. TB is #4. So why do we know about histoplasmosis? Because we have leishmaniasis in French Guiana, and the dermatologists in the 80s were scraping the leishmaniasis lesions in some, or what they thought were leishmaniasis lesions in HIV patients, and they found histoplasma. So they very early we knew it was there. So it's since then we've been very vigilant towards this pathogen. And the incidence rate is 1.5 per 100 patient years. So, and this is for the overall HIV cohort. When you stratify on CD4 count, the incidence for those, you can see here, the incidence gradually increases as you fall below 200 CD4 counts, and below 50 CD4 counts, the incidence is higher than 10% per year, so very high. So this was French Guiana, but what in the Americas, what does AIDS look like? Well, there's not much data describing this. In Panama, where the first case was described, in autopsy studies, 7.6% of patients had culture positive H. capsulatum. Now, not all histoplasmosis cases are culture positive, I should emphasize. In Guatemala, histoplasmosis is the #1 opportunistic infection with TB. In Venezuela, in patients with AIDS, histoplasmosis was documented in 44% of autopsy studies. In Colombia, also histoplasmosis is among the top opportunistic infection. In Brazil, Fortaleza, 43% of 378 consecutive patients were in fact histoplasmosis cases. And in French Guiana, in a study for 2 years, 42% of patients with fever, HIV patients with fever with less than 200 CD4 counts were histoplasmosis. And among those who had fever, 85% were histoplasmosis. So our motto was first fever in HIV-infected patients, first think histoplasmosis. And we conducted a research project with Suriname, and where they didn't have any diagnostic tool, and we did a recent study, and in fact 25%, 1 in 4 HIV patients hospitalized for fever had histoplasmosis. So these are just spotlights in the dark, because there is very there are very rare publications on the topic in Latin America. This was a recent poster at CROI in 2015, a multicentric study showing that culture-negative TB is associated with increased mortality. And the increase in mortality was 79% increased risk of death among those who were culture-negative TB. And the conclusion was that maybe there was something else. And that something else is a large portion of it is probably histoplasmosis. So in the Caribbean, the reports, there are some published studies that are mostly from the 70s, and they concern some histoplasmin skin tests, and histoplasmosis has been found in Haiti, in the Dominican Republic, where I think last year or 2 years ago there was an epidemic and people going in a cave with deaths in immunocompetent patients. In Cuba, Jamaica, Puerto Rico, Guadeloupe, Martinique, Barbados, Suriname, and Trinidad. And in Guyana, the skin test positivity rate was 29%, and in Trinidad it was 42%. So there is histoplasmosis in the Caribbean. So the barriers, why is it so difficult? Why is it why are there so few studies? And why does it feel like a neglected disease? First, there is no need to convince mycologists. We've traveled in many countries, and the mycologists are usually very aware that it's there, usually a bit lonely and depressed because nobody believes them. Many clinicians need convincing because since there is no diagnostic tests, they're not really always convinced that it's there. Often clinicians are reluctant to perform invasive diagnostic procedures. We are very aggressive. In French Guiana, we do bone marrow as soon as we suspect that histo might be there, or liver biopsy, or endoscopy, or lymph node biopsy, tissue samples to look for the fungi and to grow the fungi. And often clinicians are not always in contact with the lab, so there's a miscommunication, or when samples are taken, for example, if the biopsy is in formalin, so it cannot be grown, or when liver biopsy is done, there is no specific staining for fungi, so it cannot be found. So these are also reasons not to identify histoplasmosis. There are a couple of urine antigen detection tests, EIAs, and the first one and the one that's most used is in the USA, in Indianapolis, and it's only done there. So in the USA, the samples are shipped there, are flown there, and but the test is not commercially available. And so for all practical purposes in Latin America and the Caribbean, there has been no simple, cheap, non-invasive diagnostic tests. So if you have no diagnostics, you have no data, and then if you have no data, it's not a problem. So why develop diagnostics? So it's a bit of a vicious circle in many countries. Now, one could argue that with increased antiretroviral coverage, the problem would go away as people increase their CD4 counts. But human behavior stays human behavior, and still a lot of patients come very late and thus are at risk for histoplasmosis, and some patients have adherence problems or are lost to follow-up, and they're also commonly infected with histoplasmosis. So despite the progress with ARVs, histoplasmosis still has a bright future because these behavioral problems remain very frequent. Now, there were a few studies, but when you connect the dots and you try to factor the calculations that the numbers that we have, if you take the Americas, UNAIDS said that there were 1.6 million HIV patients in the Americas and the Caribbean. The incidence we calculated in French Guiana, but it's similar in another cohort, is about 1.5 per 100 person years, which means that there should be 24,000 cases per year. And mind, this is 1.5 per 100 person years. This is in French Guiana, where 90% of the patients are on treatment and 30% of the patients are diagnosed before with less than 200 CD4. So it's a pretty good situation. But still, it's probably higher than that in countries where testing and treatment are not as good. So 24,000 cases, and if we take the 40% mortality scenario, which is conservative also, it's about 9,600 deaths per year. So if you graph this, and this is the number of AIDS deaths in the Americas and the Caribbean per year, about 47,000 deaths from AIDS. This is the deaths from HIV-associated histoplasmosis, and these are the deaths from HIV-associated tuberculosis from PAHO, and this is malaria. When you go to the American Society of Tropical Medicine, you have a lot of malaria, but less than 100 deaths from malaria in the Americas. So what this shows, what this suggests, that is the mortality among HIV-infected patients is the mortality from histoplasmosis is on par with that of TB. These are just estimates. Now, Antoine Adenis, who works with me, has just tried to refine the estimates and do a country-by-country analysis, and with different scenarios. A very optimistic one with 10% mortality, 20 and a 40% mortality. Now, actually, this paper is in revision at Lancet Infection Disease, and the reviewer said that the 10% mortality rate is too optimistic, and we should look at 60% mortality rates. So, but basically what this shows, if you look at the dark gray parts, it shows that similarly that TB mortality and histo mortality is on par. They have a similar magnitude. So this led to a map, country by country map, and so far it's only for Latin America. We have a student who's doing this on a global scale, trying to do a burden study. But what you see is on the right you have the TB, and on the left you have the histo. So Central America and the Amazon has very high histoplasmosis incidence. These are slides showing that, in fact, here there were, at the beginning of the year 2000, there were about 7 clades in the world, and here in French Guiana and Suriname, we already have 3 new ones. So there are probably even more in the Caribbean, because the sequences of the fungi are few, and we see that there is some biodiversity. So with this cooperation in Suriname, with the test, the research, now they have been finding a lot more histoplasmosis, and itraconazole use has increased. So it wasn't there. Once the diagnostic tools are there, it's everywhere. And diagnosis, this is a slide that shows that while mortality, the bars show mortality now is under 5% for histoplasmosis, but the number of diagnoses increases. So we're by being aggressive and thinking about histoplasmosis all the time, we find it more and more. We treat it earlier and earlier, or we treat it better, and this saves lives. Now, in the highly endemic areas, the question is it TB or histo? It's always the same question as the beginning when Mr. Darling thought that he had TB when it was histo. And this shows mortality of histo and TB. So slight increase in mortality in histo patients, and there you see the incidence, and as the lower the CD4, the likelier it is histoplasmosis. So basically, what do we do? Well, usually we treat histo first with amphotericin B, and we reevaluate quickly. And if things are not better, maybe we think about TB. We do this because of the risk for the severe forms, the septic shock-like forms where patients die very early. Now, I'll go into more clinical details. Now, what does it look like? So you can have different presentation, a subacute presentation where patients have fever or usually weight loss, fatigue for 1 to 3 months. And another presentation, the septic shock-like presentation, where patients arrive and usually rapidly die if nothing is done. The presentation is non-specific often. You have fever, fatigue, weight loss, there may be cough, breathing problems, enlarged lymph nodes, enlarged liver, spleen, there may be meningitis. A common presentation is diarrhea, febrile diarrhea. There may be skin lesions, I'll show you some pictures, and mucus lesions, and there are all sorts of localizations. And there are some severity factors which I'll show later, but mostly increased LDH, decreased platelets, renal failure are a severity factor which should induce to treat with amphotericin B rather than itraconazole. So these are skin lesions. The person on the upper left, you see lesions that look a little bit like acne with a kind of umbilicated center or a crater. And this is looks very much like this is and if you scrape that, you would find Histoplasma capsulatum. The other patients have mucus lesions, even sometimes with perforation, and some of the lesions may even sometimes be mistaken for a tumor. X-rays may show condensation or aspects that would evoke a miliary. Here the CT scan shows an increased lymph node, and this lesion here shows a narrowing of the rectum, which could look like a cancer. So very different presentations. And if we go back to the differential diagnosis with TB, what can we say? If you look at the size of these circles, basically for histoplasmosis, usually you have more symptoms of the abdominal sphere, like diarrhea or enlarged liver. Whereas for TB, you will have more respiratory symptoms. Although you see that there is some great overlap, so it's not easy. And in terms of biology, there is histoplasmosis. Often you have liver test abnormalities, increased TGO, and cytopenia, anemia, low platelets, low white blood cells. So these, when you have these factors, someone with a large liver, low cell counts, and we tend in our endemic region to think histoplasmosis. But it's not easy. And what is important is to be suspicious of it. It's like meningitis. If you think about it, you have to do the lumbar puncture. Well, for histoplasmosis, if you know that it's in your country, if you think about it, you have to go and look for it. And until we have better methods, in many places it's bone marrow or liver biopsy. Endoscopy can be for a patient with diarrhea. In Brazil, they do the Buffy coat, and this man with a blindfold is there to illustrate that usually we don't wait for the results because culture may take 4 to 6 weeks to grow. So if we wait for a positive culture to treat, the patient may be dead. So usually we look for it and we start to treat it on empirical grounds. But there's a game changer ahead because there are a number of ELISA tests who are coming on the market. There's one that's on the market that's fair, and there's some new ones who are about to come on the market who are very good. And there are even some lateral flow assays which will hopefully hit the market very soon. So the treatment, in severe cases, the best treatment is IV liposomal amphotericin B, which is very expensive. And in non-severe cases, itraconazole 600 milligrams for 3 days, and then loading dose, and then 400 milligrams per day. Once the patient is better, there will be secondary prophylaxis until the patient is better. In endemic areas with incidence where incidence is very high, some people give primary prophylaxis. Now, you have to be suspicious of histoplasmosis. And this, I'll give you a few case reports. So first patient, 38-year-old Haitian man, in the ER for fever and fatigue. He has been having fever and lost weight for 15 days. He lost 7 kilos. He has no medical history, and he just takes paracetamol for fever. The ECOG performance status shows 3.5, so this person lies down for most of the day. He's very fatigued. The fever is 39 degrees, sorry. He has oral candidiasis, and he has lymph nodes a little bit everywhere, dry skin, and prurigo. The blood tests, the blood counts are performed. We take a blood culture for bacteria, dengue and malaria negative urine dipstick. The chest x-ray is normal. The HIV rapid test is positive, so the patient is admitted. On day 2, the performance status is still 3, still fever. The blood tests come back. He has 24 CD4 count. He's anemic. He has low platelets. The kidney function is normal. The TGO is increased, double the normal. He has an increase in LDH, and the ferritin is increased 10 times the normal. We do an ultrasonography, an ultrasound, which shows hepatomegaly, enlarged liver and spleen, deep lymph nodes. So the diagnostic hypotheses are, of course, histoplasmosis, enlarged liver, anemia, low platelets, increased liver enzymes. Remember the digestive sphere and the enzymes. Could be TB too. Could be a lymphoma. It could be another opportunistic infection. So in the context, what do we give? We go for mycology. So we do bone marrow aspiration with direct examination plus culture. And we look for, of course, mycobacteria, and we look for lymphoma. We do a tuberculin skin test, liver biopsy if the bone marrow is negative. So the main hypothesis here is severe disseminated histoplasmosis. Because of the epidemiology, because of the very low CD4 count, the cytopenia with platelets below 100,000, increased LDH and ferritin, TGO higher than TGP, increased spleen. So immediately on day 2, we start antifungal treatment with liposomal amphotericin B, 3 milligrams per kilo per day IV. On day 4, the bone marrow examination is positive for Histoplasma capsulatum. The blood cultures are negative for bacteria. The fever has decreased. The general condition is slightly improved, and we adjust the treatment and start itraconazole for a relay. So on day 6, the patient has no more fever. The skin test, TB skin test, is negative. The patient's condition has improved. We adjust the treatment, stop the amphotericin B, and start and continue the itraconazole. On day 10, the patient is discharged and continues itraconazole and cotrimoxazole for prevention. The patient is followed in the HIV clinic on day 17 and 40. The culture is positive for Histoplasma capsulatum. It took 3 weeks. We start ARVs, check for adherence and health insurance, social aspects, and there's no need to delay antiretroviral treatment for fear of iris. Iris immune reconstitution does occur, maybe sometimes a bit bumpy, but this is with the exception possibly of if the patient has meningitis due to histoplasma, there we would wait, but in other cases there is no contraindication to start early antiretrovirals, and antiretrovirals increase the prognosis and reduce the risk of death from histoplasmosis in another analysis that we did. So the treatment in HIV-infected patient, severe forms, amphotericin B IV until clinical improvement. So if it's 0.7 milligrams per kilo per day, if it's the deoxycholate standard formulation, or if you're lucky to have the liposomal formulation, which is very expensive, 3 milligrams per kilo per day for the liposomal formulation. And so for the non-severe forms and for the relay of the amphotericin B, it's itraconazole 400 milligrams per day orally. And there's a loading dose for the first 3 days to reach stable concentrations. So the prognostic factors which help you choose, are you going to give amphotericin B first and then itraconazole, or start with itraconazole straight over? So the prognostic factors are respiratory failure, renal failure, cytopenia, these are different, and dyspnea, respiratory difficulties, poor general conditions, low platelets would be arguments to start with amphotericin B. The second case report is a 35-year-old French woman. She's been in French Guiana for 10 years. She has no health insurance, no family. She's homeless. She's in the ER for abdominal pain and diarrhea. She's had diarrhea for 4 weeks. She's a crack addict and she's HIV positive. She was diagnosed 5 years ago at the same time when she had TB. And she only took 4 weeks of anti-TB treatment and then was lost to follow-up. There's no treatment. She doesn't take any treatment at the time of admission. So she has a 2/5 performance status. She has fever. She's lost 10 kilos. She's dehydrated, has abdominal pain, and she has diarrhea 4 times a day with sometimes some blood in the stool. The blood tests are, we do some blood tests, stool analysis, blood culture, dengue and malaria negative, negative urine dipstick, normal chest x-ray, HIV quick test positive. She's admitted. On day 2, she's still the same fever, 38, diarrhea. She has 10, her CD4 count is at 10. She's anemic. She has platelets 125. She has acute renal failure. She has increased liver TGO, increased LDH, and increased ferritin. The abdominal ultrasound shows increased liver size and spleen size. So again, the diagnostic hypothesis, histoplasmosis or TB. The medical prescription, so we perform colonoscopy with biopsies for mycology. So a piece goes to mycology, a piece goes to the bacteriology, and a piece goes to pathology, which requires some specific sample handling. She gets bone marrow aspiration with mycology, direct examination, mycobacteriology, and cytology. Tuberculin test, liver biopsy. So the main hypothesis is disseminated histoplasmosis because of the diarrhea with blood and negative stools. The presumptive antifungal treatment is given by itraconazole. On day 4, she's better. And the colonoscopy shows that she has several ulcerations on the upper part of the colon and the rectum, and the biopsies are positive for histoplasma. So the treatment is continued. So these are the images. So here you have ulcerations, and these are ulcerations due to Histoplasma capsulatum. On day 8, she has no more fever, she has less diarrhea, her general condition is better, her tuberculin skin test is negative, and she's discharged with a treatment of 400 milligrams of itraconazole plus cotrimoxazole. She's followed up at the HIV outpatient clinic, and the bone marrow and culture is positive for histoplasma. The culture of the biopsy, the colon biopsy, is also positive after 5 weeks. And so we start heart. So these are 2 examples of different presentations of histoplasmosis. And this is the poster for a meeting that took place in Paramaribo 3 years ago. And it's called 80 by 20. The goal was to have 80% of hospitals with proper diagnostic tests and treatment by 2020. So since then, what has happened? So last summer, histoplasmosis added to the advanced HIV disease management. So it wasn't there before. Now it's there, mentioned for Latin America and the Caribbean. Amphotericin B was on the essential medicines list, and now itraconazole for the first time is part of the essential medicines list, which is important because not every country has itraconazole. So now, since 2017, it's on the essential diagnosis list. The next step, actually next week, will be in Uganda to try to get on the WHO essential laboratory test list to have some antigen detection tests on that list, so that these tests hopefully will be more widespread and awareness and diagnosis will increase. And as I said, there are some new tests ahead, much easier than bone marrow, aspiration, culture, etc. Urine EIAs or LFAs are on the way, and their performances are quite good, over 90% sensitivity and 99% specificity. So this is where we are. 80 by 20 is we're halfway. The tests are a bit slow to come, but they will be coming. And so my intention here is, you have to be, my message is, you have to think about it. If the diagnosis until now is difficult, you need to really think about it, go look for it, and hopefully in the very near future we will have tests that will allow us to be much more systematic and to make diagnosis more easily. Thank you for your attention.
Thank you so much, Professor Nacher. We have a few questions, and I'll start with one of the questions from the participants is asking, what can be used in the case of itraconazole allergy?
What can we use? Sorry?
In the case of an allergic reaction to itraconazole.
Well, there are other antifungals. I mean, in the Caribbean, some like in, I know in Guyana, Ruth Ramos uses fluconazole at very high doses, but fluconazole is not very effective against histoplasmosis.
Okay, a few more questions. So, as I listened to the presentation, I know that you said, really and truly, you're at risk for histoplasmosis depending on your CD4 count. So the recommendation was that primary prophylaxis should be considered for patients with CD4 count less than 200, but even more so for patients with lower CD4 counts. And we've seen the slide that you had where, you know, the lower the CD4 count, the higher the incidence of histoplasmosis. But at the same time, you said also that primary prophylaxis really is offered in really high endemic areas with really very high incidence. I think it was 10 per 100 person years. But I'm wondering too, if many of the Caribbean countries, we don't have that data in terms of what the incidence is for histoplasmosis, because we're unable to diagnose histoplasmosis. And on the other hand, we have a lot of our patients who are coming in with very low CD4 counts. How do you deal with a situation like that? You know that you have histo, but we don't have the incidence defined, we don't have the burden defined, and we have patients coming in with low CD4 count. How do we deal with that in the context of primary prophylaxis?
Well, Actually, it's a very interesting question, and um, we looked at it is feasible primary prophylaxis when you look under 50. You are over the American guidelines is if you're in a very high endemic area and you have an incidence that's greater than 10% per year, you should use primary prophylaxis. Well, in our context, where skin test is positive in 30% of the population, when you're less than 50, we have more than 10% per year who have histo. So theoretically, we should be giving primary prophylaxis. And some physicians do, but not all. And the question, what we would like to do, and what we are trying now, is to do a more targeted approach. And we're using some research ELISA kits for urine antigen to screen all HIV patients with less than 200 CD4 count to see um, if they are positive for histoplasmosis antigen. Because what I present here is I present patients who come with symptoms. Now, I don't know how long, in fact, the dissemination may take a long time. Maybe the infection was creeping up, for months before it became symptomatic. As the immunity declined, the infection gained control. So we're trying to look in detail at the natural history of histoplasmosis. And maybe if we see that like in patients with less than 200 CD4 counts, a number of them have positive antigen but no symptoms. This is what we're trying to see. And in that case, if patients start to have positive antigen, then we treat them to avoid the development of symptoms. But we're not sure yet. We have a very binary vision of the problem. It's there or it's not there. But maybe it takes a long time before you start having the first, weight loss and fever. We don't know yet. It's like for crypto in Africa, where you screen and some patients are positive and they don't have yet symptoms. So I didn't answer your question. Some give primary prophylaxis because in the most immunosuppressed patients, but not all do. Not all are comfortable doing it because they're
Okay.
afraid of resistance, of other fungal agents
I have a question specifically in relation to Diana's TB program. And I know that you shared the findings from CROI 2015, where you said I think it was more than 75% increase in mortality among patients who were culture negative for TB compared to those who were culture positive. So in our context, and I don't know if it's similar for other Caribbean countries, but I know in our context, a lot of our TB patients, quote unquote TB patients, are actually culture negative TB patients, but we manage them for TB. We also know at the same time that we have cases of histoplasmosis because we have diagnosed a few cases of histoplasmosis. And we also know that mortality among our TB HIV patients is very high as a result of quote unquote TB. If you can just share your thoughts on what you think is happening here.
I'm sorry, I didn't understand the end of the question.
If you can share your thoughts, because one, there are a few things happening. One, it's a lot of culture negative TB, but we're still treating them for TB. We know that there is histoplasmosis in Guyana, and thirdly, that there is a high mortality among the TB HIV, particularly the culture negative.
Yeah. I think that definitely when the histo test, the antigen tests will come, I think all the TB wards should check for histo, because in some places, even in French Guiana, it's about 10% of histo cases who are also TB, or TB cases who are also histo. They go together. And I think in Guatemala, a very large number of patients have both. Because you see, if you have TB, you have TB. But if you're immunosuppressed and you're living in an endemic country, you may very well also have histo. So a number of patients have both, which can lead to some treatment problems, because if you use rifampicin, and rifampicin with itraconazole is going to make it complicated, because the enzymatic induction will reduce the concentrations of itraconazole. So sometimes you have to not use rifampicin and use rifabutin. It can be quite complicated. But I think TB, a lot of TB patients, as I was saying, you can describe histo as a TB-like disease. We tend to discuss it to describe TB as a histo-like disease. It depends on which side of the issue you're standing. But definitely TB wards, all patients should be screened for histo, especially the culture negative patients.
So there's one more question, and that is, so we recognize the barriers that you shared, that clinicians are reluctant to really do some of the invasive diagnostic procedures. But on the other hand, in some of the contexts in which some of us operate, is that even if there isn't that reluctance to do the diagnostic procedures, we do not have the necessary backup laboratory diagnostic capabilities to be able to test the samples. And so what's your take in those cases, and maybe particularly in relation to empiric management?
I think a lot of, like in Brazil, a lot of places where even they do, but they don't communicate. The clinicians, once they know that it's there, they use empirical treatment, and they probably save a lot of patients like that. I think in Suriname, before they started to grow the fungus, I know that they were Dr. Vreden was using a lot of empirical treatments successfully, although the pathogen was not identified because for lack of diagnostic capacity. So I think that's why I insisted very much on the suspicion, because I think histo is in the Caribbean, is everywhere. I cannot say if it's. I think the Caribbean territories are diverse. I think in Trinidad, for example, it's very close to the continent. I think histo is everywhere. I've been there, and I think the clinicians know it, and the lab people know it, and they want better tests because the diagnosis is difficult. I'm not sure on smaller, drier islands if it's the case, if you can only find it in caves or things like that, because histo does need humidity, and then it needs to grow, and then usually when it's the dry season, the winds disperse the spores, and that's how people get infected. But I think when we get these antigen tests, I mean, all you need is urine, and you can have the result in a few hours. Then we will be able to really describe the burden of disease, and not just try to speculate with very sketchy and poor data, which is the best we can do so far. So we really need a burden study that will cover all the territories to know where do we stand, where does my territory stand regarding histo in HIV patients. Because HIV patients basically will be the revelator of histo, because they're immunosuppressed. So if you don't find it in HIV patients, it's probably not a big problem in your country. But if you do, it's there.
Okay, excellent. So we look forward to the antigen testing. I think there's more to come for histoplasmosis. And this brings us to the end of our webinar this afternoon. On behalf of PANCAP, the Pan-Caribbean Partnership Against HIV and AIDS, and the director, Mr. Derek Springer, and all of our attendees today, let me thank you, Professor Mathieu Nacher, for really investing your time in the webinar, sharing your knowledge and experience with the partnership. Thanks to all of our attendees who have joined us today. As a reminder, the webinar was recorded and will be posted on PANCAP's website. Please join us for our next webinar. You will receive the announcement shortly. Finally, I urge you to continue to stay engaged with the regional response. Follow us on our social media platforms, Facebook and Twitter, and look out for our next announcement for the upcoming webinar for April. Thanks again to everyone and have a great Easter holiday. Thank you.
Thank you. Bye-bye.